Hello and welcome everyone to tonight's Influenza Update webinar presented by ACT Health and the Capital Health Network. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. Tonight's webinar focuses on the 2024 influenza season and vaccinations, as well as some other updates on COVID-19, RSV, and shingles. I am Dr. Leonie Harcourt, a GP Education Advisor at the Capital Health Network. Also with me tonight is Dr. Ryan Burns, a fellow GP and Public Health Registrar from the ACT Health Directorate, and Dr. Philip Britton, the Head of Infectious Diseases and Microbiology at the Children's Hospital Westmead, and of course, Kanal Mohiti, the Events Lead at Capital Health Network. So on to housekeeping. All participants have been muted. Please type in any questions into the Q&A section of your Zoom panel, not into the chat box, so into the Q&A section. We'll have a question and answer session after both Dr. Britton and Dr. Burns have presented. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. With respect to CPD, there will be a QR code posted at the end of the event, and please complete the evaluation survey attached to the QR code. CHN will email you out a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. And also just to highlight health pathways. Health pathways, as you probably all are aware, are up-to-date guidelines and advice on the treatment and investigations of common conditions such as influenza and other infectious diseases. The login for health pathways is together, all one word, lowercase TOGETHER, and the password is for health, FORHEALTH, all lowercase. So now onto the presentations. Our first speaker tonight is Dr. Philip Britton. Philip is a paediatric infectious diseases physician and head of diseases and microbiology of infectious diseases and microbiology at the Children's Hospital Westmead, and also the conjoint associate professor of child and adolescent health at Sydney Medical School at the University of Sydney. His research focuses on severe infectious diseases in children, especially neurological infections and severe acute respiratory infections. Philip's other research areas include tuberculosis, travel-associated infections, tropical diseases, and staphylococcus infections. So over to you, Philip. Thank you very much.
Wonderful. Look, thank you for the kind introduction and the opportunity to speak with you tonight. I hope it's going to be educational and interesting. And so I'm going to give an overview of respiratory viral disease in kids, particularly focusing on influenza, COVID-19 and RSV. And hopefully that'll be a broad introduction to the specific and important update with respect to the program, influenza program and other vaccine programs in the ACT. So here we go. So it won't be new to anybody on tonight's call that there's lots of respiratory viruses that are important in children. This is data from New South Wales Health Pathology that's published on a fortnightly basis through the New South Wales Health Respiratory Viral Report. You can see that in that report, which is publicly available, you can Google it, there's reports on COVID-19, on influenza, RSV, and then increasingly on adenovirus, enterovirus, human metapneumovirus, paraflu, rhinovirus, RSV. You can see there's a lot of these viruses. And we've been interested in them in my research group for some time. And on this slide, this is work of a PhD student of mine, Rebecca Burrell, who's done a fabulous piece of work looking retrospectively at all respiratory viral testing done at the Children's Hospital at Westmead between 2014-19. And without going into detail, what you can see here is across 12 different respiratory viruses in children, the average seasonal pattern of disease over that study period. And so you can see that if you just from the big picture, you look at this, you can see there's respiratory viral activity throughout the calendar year. But in particular, there's this sense of peaks in viral activity starting from about late March, running all the way through to October with serial waves, starting off with respiratory syncytial virus there. You can see in the top row, second and third columns. And then we have our flu wave in the third row in the first column, and in the fourth row in the second column, flu A and B. And then we move into human metapneumovirus, first column in the second row, first column, and para-influenza type 3, second row, final column. So this just gives you the scope and scale of respiratory viral disease in children. Finally, by way of introduction, I wanted to just tell you a little bit about a surveillance network, a Commonwealth Department of Health surveillance network that I co-lead, that's hosted here at the Children's Hospital Westmead, called the PAEDS network, Paediatric Active Enhanced Disease Surveillance Network. We've been going now for over 15 years. And what we do is in 8 children's hospitals around Australia, you can see them marked there on the map, we identify actively with surveillance nurses conditions of public health importance, usually those that are vaccine preventable or may become vaccine preventable. And we recruit patients, collect enhanced data beyond the routine notification data, and do analyses that then are reported to the Commonwealth Department of Public Health and jurisdictional public health. But also we do research studies on the basis of that. And I'll be showing you a little bit of data from the PAEDS network in tonight's presentation. Now, what you all know is that winter is coming, and that's why you're here tonight. And really, increasingly, I like to talk about the big 3 respiratory viruses, both in adults and children. And why are they the big 3? Well, they're big because they cause a lot of disease. But they're also big because they are vaccine preventable or soon to be vaccine preventable. And so there's a very strong public health mandate for how we respond to these viruses. And it's important in how we'll work our way through the viruses we're going to look at tonight to understand the immunisation timeline for young children. And in doing that, I'm keen to differentiate between active immunisation, or what we would call vaccination. So we give an antigen either in a live, an attenuated organism, or as an antigen that's inactivated or generated in the laboratory. And that there's an active immune response that produces immune memory to that antigen for future reference. That's active immunisation or vaccination. That's different from passive immunisation, or what I like to call immunoprophylaxis. And there's 2 processes by which that occurs. The first is a natural process, where in the 3rd trimester of a woman's pregnancy, the placenta very cleverly actively transports immunoglobulin, IgG, from mum to baby, so that babies are born with a repertoire of antibodies that are ready to help protect that young baby on the basis of mum's prior active immunity. That's the first natural pathway to passive immunisation. The second pathway is where we might give a preformed antibody to somebody as a monoclonal antibody, and that provides immunity over a temporary period of time. It's like a drug that wanes as the half-life of that antibody wanes, and that provides immediate and passive immunity, but does not actively produce immune memory for any future episode. And so if you look at this in this figure, this is from a review article summarizing how this pertains to RSV, which we'll look at a little bit later in the presentation. What you can see is that at time 0 on the bottom, or 0 months, a baby is born, and if they get passive immunity from mum in the gold there, they have antibodies in their blood, and that wanes quickly over about the first 4 to 6 months of life. Equally, we could give a baby a monoclonal antibody at birth that would wane over a period of time. We do that for children where mum has hepatitis B, and we give hepatitis B immunoglobulin at birth as passive immunity. Equally, if we were to give a vaccine to a child, you can see there that we might vaccinate them very early, as we do in our national childhood immunisation program, with vaccines at 2, 4, 6 months, and that actively immunises the baby, and you get this vaccine protective effect that rises from early exposure and then up. But the true challenge of active immunisation in little babies is that their immune response is relatively attenuated because of their age, and so you have to give multiple doses of an antigen, and you have to wait for immunity to occur. And this timeline is the timeline that's in view when we're thinking about respiratory viruses in children. So this is what we're going to cover tonight: flu, SARS-CoV-2 or COVID-19 and RSV, talking about the virus, the disease, the burden of disease, and a little bit about vaccine and immunisation. We're not going to talk about in-hospital case management, which is actually what I do with most of my life, but we're not going to talk about that today. So let's work our way through these things. Influenza. This is a schematic of the virus. Some people like to see what it really looks like in life, and in the top corner there you can see an electron micrograph of the influenza virus. And the key elements here to pick up on are the two main antigens of importance from how we describe the virus and also from the body's immune response. And that's the hemagglutinin protein there, you can see in the purple, and the neuraminidase protein in the yellow. And it's the hemagglutinin to which we're trying to get people to produce IgG when we immunize them. And it's the H and the N that are used to designate subtypes of influenza A viruses, H1N1, H3N2. And the other really important thing about the influenza virus is that inside there in those squiggles, you can see the segmented genome of this virus, RNA, segmented RNA, 8 segments. And it's those 8 segments that contribute to the peculiar thing about influenza, which is its capacity to alter its genome over time, to undergo this process of drifting of protein structure over time, genomic and protein structure, so seasonal changes, and also shifting, where you might get one of those segments completely swapped in or out from another virus. And it's that drift, seasonal change, and shift that then can produce altered virus, and it's the shifting of viruses that produces pandemic potential of influenza. This is the blown up latest data from New South Wales Health through 6 April 2024, and you can see, at least with influenza at the moment, we are in an interseasonal phase of the virus activity, but of course winter is coming. And when we think about the disease of influenza, particularly in children, which of course is my area of clinical and research expertise, you can see on the left here, just from a review article describing the clinical manifestations of disease, which are broad in infants and preschool children and school-age children, with a focus on respiratory tract, of course, but with quite a lot of capacity for neurological, muscular complications. And if you look at the table on the right, there's a few things I want to highlight from this recently, 2023, published community-based cohort study of influenza infection from South America. And what you can see is right down in the bottom right-hand corner that 1.9% of these 2,000 children infected with influenza in this community study required hospitalization. Hospitalization was more frequent, if you follow along that row back to the left, in young children, less than 1, and then dropped a little bit between 2 and 4 and back up again in 5 to 14-year-olds. And if you look at the clinical manifestations of disease, it's labeled sequela. At the bottom of that table, you can see that pneumonia is the outstanding clinical manifestation of disease requiring hospitalization. If you look at the symptom profile in the top there, what you notice is that fever is almost universal in influenza infection in children, and that's symptomatic fever. When you look at measured fever, you can see about 2/3, about halfway down clinical sign, 2/3 will have a fever over 38. Now, if we look at this in terms of the age distribution of disease, you can see in this is data from Australia from a few years ago, you can see the rates of notifications are highest in young children between 6 months and 5 years of age, dropping off in the middle age, and then rise again in the later half of life. And if you look at the relative burden or the relative rate ratio in Aboriginal and Torres Strait Islander people compared to non-Aboriginal and Torres Strait Islander Australians, you can see that there's a discrepancy, a higher rate across all age ranges, but particularly in young children. And so children less than 5 years are at high risk of influenza, and there's an increased relative burden in Aboriginal and Torres Strait Islander background children and people. If you look at this table, this is from the Australian Paediatric Surveillance Unit. This is looking at children admitted to hospital with severe influenza under 5, and severe influenza. It's comparing children under 5 and children between the ages of 5 and 14. And what I really want to bring out here and highlight to you is underlined there. You can see that in children above the age of 5, you have a relative increase in the frequency of comorbidities in those who get severe influenza. And if you go down, you can see that there's quite a lot of complexity amongst hospitalized influenza, again, including neurological complications in 10 to 15% of admitted children. Moving down the bottom, you see pericarditis and myocarditis in a small number of older children and young children. You can see things like rhabdomyolysis or muscle disease from influenza. So again, severe complications, but it's the comorbidity that I want to highlight here as an important factor in severe influenza that is relatively more important in children more than 5 years of age. And so what are the implications of this for a vaccine program? Well, on the right, you see the National Immunisation Program for influenza this year. I know there's going to be some detail about the ACT program, but the outstanding things to say are, number one, we have a funded national program for children under 5 years of age. And number two, we have a funded program for children and young people with medical comorbidity. I hope you can see that that correlates with the burden of disease. And you also know that the vaccine changes every year because we have this drifting phenomenon of the virus. And these are the strains that are in the egg-based and cell-based influenza vaccines in 2024. If you look to the left, this is data curated by the National Centre for Immunisation Research and Surveillance, showing the vaccine coverage that we achieved in 2023 in Australia. And if you look at children under the age of 5, the vaccine coverage we achieved in 2023, despite a national funded program, was 28%. Now, we are speaking to practitioners in the ACT. You did best. You lead the league table at 50%. Fantastic. But once you get to 5 to 15-year-olds, we're still maxing out at a coverage of 16%. And so we have a long way to go on influenza vaccine coverage in children and young people. And there's a lot of work to do. And that's why webinars like tonight are so important. But one of the challenges that we face with influenza is that vaccine effectiveness is never optimal, or has never been optimal. So in children and young people, we achieve about a 60% vaccine efficacy against hospitalization year on year, or averaged, and that it's better for H1N1 on average than the other influenza viruses. And reassuringly, it's better in children with medical comorbidity on average too, but it's suboptimal. So that's influenza. So let's move on to SARS-CoV-2 or COVID-19, and we're going to work through in a similar way to we did for influenza. So this is the virus. And again, you can see in the top right what it really looks like under an electron micrograph. But the key things to bring out here, the key thing to emphasize in this schematic is it's the spike protein that is the key protein against which we're trying to generate an immune response through immunization or vaccination, and against which natural immunity forms. And it's the spike protein that is the key protein in infecting human cells. And this is the latest data for COVID-19. The y-axis is a bit different to the one for flu, so I don't want you to focus too much on what it visually looks like, but more look at the trend. And what you can see is that COVID-19 transmission and disease in New South Wales at the moment is in a lull. We've had a wave over the December-January period, but we're in a lull. And COVID-19 disease in children is quite variable and complex, and we can't go into it in great detail tonight. This is a schematic from a review article I wrote with a colleague of mine, Dr. Annalise Howard-Jones. And what this is trying to illustrate is that from time of infection on the y-axis and severity on the x-axis and severity on the y-axis, there's 4 big groups of disease in COVID-19 in children. The first group is acute uncomplicated COVID-19, and that's mild there in the teal. It looks like a small triangle, but in fact, it's the most important triangle in terms of the total infection burden. Then we have moderate disease, and that we call acute complicated COVID-19. Often those children require hospitalization. That occurs a little bit later in the disease course. A third group, an important group to emphasize, which is very specific for children, is post-infectious COVID-19, or what's known as Paediatric inflammatory multisystem syndrome, temporally associated with SARS coronavirus type 2, or PIMS-TS, that's much easier to say, known in other parts of the world as MIS-C. That's the third group, and on average, it's the most severe manifestation of COVID-19 in children, although it's very infrequent now. And then the final group in the grey triangle is the post-acute sequelae of SARS-CoV-2, or what's sometimes called long COVID. And you can see that that happens after the acute phase and then extends on, and there's still a lot of uncertainty around what long COVID in children really looks like and its burden of disease, particularly in Australia. But the key message is that 99% of childhood SARS-CoV-2 infection is mild or uncomplicated. Okay. And what does that look like? Well, you can see that fever occurs in about half of cases, cough in about a third to half. Then you have rhinorrhea, sore throat, dyspnea in about 15%. If you can, that's on the left in that figure from another review article that Annalise and I wrote. On the right, you can see data from the UK comparing younger children and older children. And actually with SARS-CoV-2 infection, on average, disease is more prolonged and more severe in older children. You can see the frequency of symptoms and the duration of symptoms on average being higher in older children. So as distinct from influenza, in SARS-CoV, where the asymptomatic fraction is relatively small in children, in COVID-19, the asymptomatic fraction is quite high. Approximately half of all infections are asymptomatic, and children who get SARS-CoV-2 infection tend to be more symptomatic as they're older. There's a huge literature on risk factors for more severe disease apart from age. And this is a summary of the literature on risk factors for SARS-CoV-2 infection in children. You can see being very young, as well as that symptomatic worsening with age. You can see medical comorbidities important. And on the bottom of this slide, you can see this is data from very big administrative data sets in the US, looking at medical conditions associated with hospitalization in the first figure, and on the right, hospitalization resulting in severe disease or ICU admission. And really one of the interesting things about SARS-CoV-2 in children is that although all medical comorbidities do increase risk, the balance of medical comorbidity is a bit different. And what we've really seen is that the metabolic risk factors like obesity, diabetes, have been really important in older children for severe disease relative to other respiratory viruses. And things like immunocompromise seem to have been less important for SARS-CoV-2 relative to other respiratory viruses. In terms of the current burden of disease at a national level, on the left here, this is the PEDS network dashboard for hospitalization, COVID-19 hospitalizations detected by our network. It's publicly available. If you Google PEDS and then follow through to COVID-19, you'll find our monthly updated dashboard. You can see we've collected data on over 6,000 admissions of COVID-19 in children in Australia. You can see that the frequency of admissions is declining since mid-2021, when we saw the Omicron variants come around. You can see that the ICU admitted proportion stayed reasonably stable. You can see we've had these waves coming, and that we're in a wave that's waning at the moment. We also know from other work we've done, serological surveys we've done, that now since mid-2023, we know that 85% of children in Australia, whether they've had vaccine or not, have got evidence of antibody immunity to the spike protein of SARS-CoV-2. And it doesn't really project very well, I'm sorry, but in the bottom right, this is a table from a paper we published looking at ICU admissions in children. And what that shows in summary is that although there was an increase in the number of ICU admissions in children with widespread transmission of SARS-CoV-2 and the Omicron virus strains, the actual infection-related risk of admission dropped considerably, partly mediated by vaccines in older children, but also partly mediated by an apparent reduced virulence of Omicron, and I think that's uncontroversial now. So what are we seeing with the burden of disease from COVID-19? Well, we're seeing reduced infections with time, reduced hospitalizations with time, and reduced risk of severe disease, except in very young children. Now, I did want to briefly talk about that post-infectious inflammatory disease in children, PIMS-TS. We also do surveillance for this for the Commonwealth Department of Health. And on the right is our PIMS-TS dashboard, which you could Google and look up. And you can see that we've identified almost 200 cases of PIMS-TS in Australian children since the onset of the pandemic. We saw a significant rise in the frequency, the counts of PIMS-TS in 2022, again, as we saw the Omicron waves come through. But since that initial widespread infection, we've seen a real drop-off in the frequency of this disease. There have been no deaths in Australia associated with PIMS-TS or post-infectious inflammatory COVID in children, unlike in other parts of the world. And you can see it is quite severe. 25% of these cases go to ICU, and the majority are in children over the age of 5, with a median age of 7.8 years, and that we're seeing this significant drop-off in the frequency. So where are we at with COVID-19 vaccination in children? Well, you can see in terms of primary vaccination, in the top left, there's no vaccination recommended for children under 5 for a primary course. For children over 5, a primary course is recommended. And there are still many children out there over 5 who've never received a COVID-19 vaccine. If you look down at the bottom left, you can see a summary of booster recommendations. And if you look at the bottom, for children under 5 years, there's no boosters recommended. For children over 5 years, they are eligible for a booster every 12 months if they have immunocompromise or other conditions that put them at risk of severe COVID-19. And on the right, there's a summary of those conditions for children under 5, where though there's no primary course recommended for all comer children under 5, for children with severe immunocompromise, complex disability, or complex health conditions, there is a recommendation for COVID-19, and those conditions are summarized on the right there, and that's available on the COVID-19 vaccination webpage at the Commonwealth Department of Health. So moving on now, I'm going to talk a bit about respiratory syncytial virus and some new developments in that area of relevance to childhood immunisation. And here again, following through in the structure that we've got used to now for influenza and SARS-CoV-2, this is the virus, a schematic of the virus. If you're interested in what it looks like in real life, there's an electron micrograph there in the top right. And the really outstanding things to point out here with this virus, which is also an RNA virus, are the F protein and the G protein. F for fusion protein, that's the key protein that this virus uses to bind to human epithelial cells in the nasopharynx and the lung, and the glycoprotein, which plays a role in attachment. And it's the fusion protein that children develop an antibody response against, and it's the fusion protein that we are hoping to immunize against as preventative tools come online. In contrast, it's the attachment glycoprotein that differentiates between the two main subtypes of RSV, RSV-A and RSV-B. And again, this is the latest New South Wales health data. And in contrast to influenza, where we're at an interseasonal type level of activity, and COVID-19, where a wave has waned, we are right in the pickup of RSV in New South Wales. It's been a little bit earlier than we have seen in the pre-pandemic years. You know, there's been a lot of disruption into the normal patterns of respiratory viruses by the pandemic. So a little bit earlier than expected in February, but we're starting to see an ongoing rise into March and now April. And what about the disease caused by RSV? Well, RSV can infect the respiratory tract and cause a whole myriad of respiratory tract manifestations, from ear disease to a cold to pneumonia. But the outstanding clinical disease is this disease called bronchiolitis that happens mainly in young children. And what you see with this virus is, instead of this on the left there in the schematic, this broad, patent, small airway in the lung, that gets swollen, you get constriction, you get mucus buildup and inflamed lung airway wall, and all of that produces small airways obstruction, mucus plugging, blocking of the ability of the lung to clear air back out, so hyperinflation of the lungs, and you get collapse of other parts of the lungs, atelectasis, and you end up in small children with chest x-rays that look something like this. You can see this is a young baby with an, at the top, you can see they've got an endotracheal tube down into their lungs, and you can see their lungs, all of these areas of darkness in the lung fields, patchiness that extend out from the center of where the heart sits all the way out to the peripheries. On the right side, you can see that there's a darker kind of patch where part of the lung has been collapsed. And this is what makes babies very sick with this virus, RSV. And in the terms of the burden of disease in children and young people, we've talked about two viruses that cause a significant burden of disease, but RSV is even bigger. So in the top left, you can see the frequency of admission to hospital with RSV over a 10-year period. This is work done by a now colleague of mine and former PhD student of mine, Gemma Saravanos, looking at ICD-10 coded admissions in children. You can see the very large number of hospitalizations, the y-axis up to 10,000, and the age distribution on the bottom, children under 5, this very high peak of hospitalizations in children in the first few months of life, such that 3/4 of these hospitalizations are happening in children under 12 months of age. They happen seasonally. In the bottom left, you can see this is data from the Children's Hospital at Westmead with these seasonal peaks. This is pre-pandemic, with a mix and shared circulation of RSV A and B with slight variance year on year, but co-circulation every year. You can see about 14% of children in a tertiary children's hospital end up in ICU if they're admitted with this virus. In terms of rates at a population level, on the right, you can see three figures. The top figure, we have rates by time in very young children under 2. In figure B, it's the rate by time in children between 2 and 5. And in the bottom, you can see the rates in older children and adults. And the reason they're separated is that the y-axes are completely different. In young children under 2 months of age, you can see rates of admission of nearly 3,000 per 100,000 population. So that's 3% of children admitted to hospital with this RSV if they're infected under 2 months of age. And that reduces as children get older, but still at 1% for children 6 to 11 months of age. You can see in 2 to 5 year olds, it's more like 30 to 60 per 100,000. And in adults, it's well less than 5 per 100,000 until you get above 65. And you can see that in this period of study, you see this very significant rise in the frequency of hospitalization in adults over 65. That's not because RSV became more frequent. It's just because we started testing in older adults. So RSV, principally bronchiolitis, as I've explained, is the most frequent cause of hospitalisation in children under 1 year in Australia and occurs seasonally in 1 to 3% of babies. But there's other elements to this burden of disease in terms of death in children. You can see at the top left and bottom left, this is a study we did of 25 years at the Children's Hospital at Westmead, looking at deaths associated with RSV. You can see the scale on the y-axis is between 1 and 3, so only 1 or 2 children each year, each one a tragedy, of course. And you can see at the bottom left, when we estimated on the basis of that tertiary hospital study, a population rate that it's about 1 in a million children under the age of 16 per year die of RSV in Australia as an estimate. And in the bottom left, you can see that amongst those children who die, medical comorbidity looms very large. Almost all of these children with death, well, all of these children who died attributable to RSV had some kind of medical comorbidity. So that's acute hospitalisation, enormous, death, relatively infrequent in our setting. On the right, this shows you the post-RSV effect in children and young people. And this is a case control study. In the black curve is cases of children who had RSV in the first year of life. In the dotted curve is controls, children who did not have RSV infection in the first year of life. And what you see is then the frequency of wheezing or asthma-coded admissions in those children over the subsequent 20 years, almost 20 years. And you can see that in children who had RSV in the first year of life, there's this strong association between early childhood RSV and ongoing burden of wheezing illness, particularly in the preschool years in those children. And so RSV occasionally causes death in Australian children, a relatively infrequent event given the burden of hospitalisation. But there's this ongoing burden of RSV where it contributes to long-term wheezing illness in Australian children. Now, it would be remiss of me to say anything about RSV to not emphasise the global burden of RSV. Now, influenza has a global burden in children, absolutely. As does SARS-CoV-2. And both of those have had a significant impact. The pandemic of SARS-CoV-2 has mainly had an indirect burden through things like school closures and effects on poverty and nutrition in children rather than a direct burden. However, RSV is really the outstanding respiratory virus in terms of global burden of disease. On the left, this just shows you the global burden of mortality and hospitalisation, hospitalisation in the top, mortality in the bottom. And you can see that that is really overrepresented in low and middle income countries in Asia and Africa. On the right is data from a pneumonia causation or pneumonia etiology study called mind blank. I can't remember what the acronym for the study was. I apologize for that. But what you can see here is that if you look at the causation of lower respiratory tract infection or pneumonia in children, if you look overall on the left, the outstanding pathogen was RSV at the very top there, as causing 30% of severe lower respiratory tract infection in children. And if you stratify it by age, which is the next figure along, you can see that in children under 1, that etiological fraction is much higher than in children over 1. And you can see on the next curve where you stratify by severity that RSV causes more severe disease. So it's a more frequent cause in children with severe disease as compared with very severe disease. So what this tells us is that acute lower respiratory tract infection is the #1 infectious cause of death in children globally under 5, and RSV is the #1 cause of those deaths and hospitalisation in children. So it's a big deal. Now, there are risk factors for severe RSV. So compared to children without any medical comorbidity, and the particular high-risk groups for medical disease are children born prematurely with lung disease or heart disease or immunodeficiency. And there are some rare genetic comorbidities. But if you put all of these comorbidities together, it's about 10 to 15% of Australian birth cohorts will fit into one of these high risk cohorts. And we have new preventative tools for RSV that are coming through. And I particularly want to talk about the long-acting immunoglobulin, or a passive immunization, immunoprophylaxis. But we do have vaccinations coming through for pregnant women, as we have vaccines for pregnant women for flu, for COVID. We're going to have vaccines for pregnant women for RSV, which all three play a role in passively protecting babies in the first few months of life. But I want to spend a little bit of time talking about a long-acting immunoglobulin called nirsevimab, or the product name is Beyfortus. And nirsevimab is a monoclonal antibody with an extended half-life, so half-life of 71 days, which can passively immunoprophylax children against RSV for the equivalent of a single season. So this product compares favorably with palivizumab, which is the current product that is used for a small number of high-risk children in Australia, which requires them getting 5 monthly injections to cover the RSV season, and is very expensive. So it's important to recognize that this nirsevimab is not a vaccine. It's not active immunization. It's passive immunization using a monoclonal antibody, and it binds to the fusion protein on the surface of RSV. And it's been shown in randomized clinical trials to protect children, young children, against RSV, hospitalization, and ICU admission with an efficacy of 80 to 90% if it's given early in life for 150 days. And this has been licensed in Australia since November of 2023 and licensed around the world earlier than that. And it's been used programmatically in several locations around the world. And this is a phase 4 effectiveness, or a post-licensure, post-implementation study in children in Luxembourg. Luxembourg chose over the 2023-24 winter to fund nirsevimab for all children under 12 months of age. You can see they achieved a coverage of 84%. And what that resulted in was a 69% decrease in hospitalizations with laboratory confirmed RSV in children less than 6 months of age. And you can see on the bottom there, on the left-hand side in the teal, is the age distribution of RSV in, admissions in children, age in months, in 2022-3. And on the right is the 2023-4, and you can see the complete dropout, or relative dropout, of RSV hospitalizations in children under 6 months of age. And what that looked like in terms of a complete epi curve, you can see on the right, the RSV epi curve in 2022-3 and the epi curve in 2023-4, and the curve stops because that's when the data was audited for this study. But you can see the reduction in the amplitude of the RSV epidemic. Similarly, this is data from Galicia in Spain. You can see the previous curves of the epidemic weeks in all of those colors. And then in the bottom, in the coral, we'll call it, you can see the case counts for the season in which they gave nirsevimab to children under 6 months with 80% coverage. You can see this massive reduction, 89% reduction in hospitalizations. So it's on the basis of this evidence that different states in Australia have negotiated for different kinds of programs with nirsevimab. There's a globally constrained supply. And in New South Wales, we were able to negotiate a high-risk, vulnerable infant RSV prevention program. And this slide just summarizes the way that program's being implemented. It started at the start of April, and we are ramping up, giving this to children within those risk categories I've mentioned: premature babies, Aboriginal and Torres Strait Islander children, children with neonatal lung disease and cardiac disease, as well as other children with high-risk medical concerns. And if they've had palivizumab, they can transition to nirsevimab. And if they've had RSV in 2024, they're excluded from the program. Now, all of this information is available. If you want to Google RSV, vulnerable RSV cohort in New South Wales, you'll get all of the information about this program. So don't worry about the details, but it's a high-risk program in New South Wales in contrast to an all-infant program in Queensland and WA. WA has commenced. Queensland commences their program at the start of May. And so, look, I just wanted to take one slide to just try to summarize that. You can see here we've got the three viruses I've talked about: flu, SARS-CoV-2 and RSV. You can see that there's differences in their age distribution of disease. SARS-CoV-2 is very young children and then teenagers. Influenzas, particularly under 5s, and RSV, particularly under 12 months. You can see the clinical disease for COVID. It's a variety of presentations, including COVID pneumonitis. For influenza, pneumonia, as well as other respiratory tract infection. For RSV, bronchiolitis, as well as other respiratory tract infection. In terms of severity, on average, RSV is the most severe in children, resulting in 1 to 3% of children getting hospitalized, as opposed to less than 1% for SARS-CoV-2. That corresponds to an increasing burden from SARS-CoV-2 to flu to RSV for total hospitalization, noting that, of course, SARS-CoV-2 or COVID-19 remains in flux. We don't know what the long-term pattern of COVID-19 in the Australian population will be. And down the bottom there, SARS-CoV-2, we have vaccines, particularly for children over 5, with very high effectiveness against hospitalization. For flu, we have effectiveness of moderate effectiveness, 50 to 70%, particularly a program for under 5s and medically comorbid children over 5. And on the right, you can see for RSV, we don't yet have vaccines, though they are coming, and there will be a maternal vaccine soon available in Australia. But what we do have is immunoprophylaxis, which has a more than 80% efficacy against hospitalization when given to very young children at birth or in the first 12 months of life, but there's limited availability for that product. And we have challenges. For flu, I've summarized, it's the seasonal drift, the need for new vaccines every year. There's still poor coverage and uptake. We have an issue with provider confidence in recommending influenza vaccine for children and the suboptimal effectiveness. For SARS-CoV-2, we have the challenge of ongoing dynamic recommendations. We have a very significant issue with vaccine fatigue and public health fatigue, for want of a better phrase, when it comes to COVID-19, and we do have the ongoing risk of variants. And for RSV, we have this challenge of community recognition. It's not been vaccine preventable or immunisation preventable in the past. We have new products with limited supply, and so unfortunately there's inequity at a national level. And so keep calm and carry on vaccinating and immunising for RSV if and when that product is available for use in the ACT. And I'm going to stop there. I want to thank you very much for attending and for listening tonight. I hope that's been interesting and instructive for you all.
Thank you very much, Philip. I found that very interesting. I'm sure the rest of the audience found it interesting as well. So moving on to our second speaker, and just a reminder, if you have any questions, to put them in the Q&A box. I know I certainly have got some questions after Philip's presentation. So our second speaker is Dr. Ryan, and he is a GP and is currently working as a public health registrar at ACT Health. He has previous public health experience in Aboriginal and Torres Strait Islander health and chronic disease management. And Ryan has also worked in the prevention and treatment of obesity and obesity-related complications in the ACT. So over to you, Ryan. Thank you very much.
Thank you very much, Dr. Harcourt, and thank you, Prof. Britton, for that really wonderful talk. Thank you as well to everyone for turning out. I hope you can see my slides there. I'll just get them sorted properly. Oh, apologies. Okay, so I will be speaking about the 2024 influenza vaccine program update from an ACT perspective. We'll touch on a few other things as well. Just looking at an overview, if my slides will cooperate, there we are. So again, we'll start with some epidemiology, just a quick look back at the 2023 influenza season in the ACT and nationally, and then move on to the influenza vaccine program for 2024, including some recommendations and priority and focus groups. Some other updates which are quite topical following on from Prof. Britton's talk, including COVID-19 and RSV, as well as a bit on shingles, some more general winter wellness information, and then some key take-home messages as they relate to the influenza program, with some useful, or hopefully useful resources on a slide at the end. So starting off with that influenza epidemiology for 2023, and we've got an epi curve here that's looking at the number of influenza notifications in the ACT from 2023 and previous years as well by week, and year of specimen collection, number of notifications on the y-axis. You can see that kind of blue bidirectional arrow at the bottom there that represents kind of the influenza season, and the red line represents the 2023 influenza notification curve. Just want to note that notified cases are only a small subset of total cases, but generally speaking, the shape of the curve still applies. Compared with the 2022 season, for example, which you can see there in the yellow/gold color, the 2023 season saw a slightly later and more gradual rise in cases of influenza that were notified, although reached a slightly higher peak and had a much longer tail. You can see kind of all the way to the back end of the year, still having even a secondary small rise towards November and December. Nationally, there was a sort of similar story, although the peak number of cases was much lower in 2023 than in 2022, although same story with that lower and slower rise, that slower rise and longer tail as well. The next couple of slides are in part to demonstrate some other surveillance systems that are in operation and more so on a national basis. So these data are from ASPRIN, or the Australian Sentinel Practices Research Network, looking at influenza-like illness presentations to Sentinel GPs, which we have about half a dozen in the ACT, again by week and with a 5-year average accounting for a couple of years of the COVID pandemic as well. And again, reiterating, this is national. So again, in red, you can see the 2023 season with a fairly similar shape, I suppose, with a different amplitude to the previous curve. And just wanted to note as well that influenza-like illness is defined by a combination of fever, cough, and fatigue in this instance. These follow the notification patterns quite well, and you can see that 2023 is quite similar to the 2022 curve in the faint orange there for this curve. Another one of these we have is symptoms reported by flu tracking participants, again by week and with a 5-year average nationally. So flu tracking is a weekly online survey with self-reporting of data. And again, you can see the red line representing 2023 with almost across the board a lower proportion of participants. So that's our y-axis for this graph, is proportion of participants reporting fever and cough. Compared with 2022 and most of the other seasons represented here as well. Just as an aside on this slide as well, certainly encourage kind of looking up and even considering participation in flu tracking, easily searchable online, and a really interesting look at how surveillance can take a few different forms. Next, we'll move on to the 2023 ACT influenza vaccine program. So some data relating to last year, as this has kind of in part informed what's happening in 2024 as well. So this table has some data from the National Centre for Immunisation Research and Surveillance, or NCIRS, looking at influenza vaccine uptake in 2023 in the ACT and nationally. So as Prof. Britton pointed out, got that 50% mark for the youngest age cohort in the ACT, and for each age cohort, the proportion of influenza vaccine uptake in the ACT, as with previous years, is higher than the national proportions. Worth noting, though, that compared to 2022, these proportions are slightly lower across the board as well. Similarly, we've got NCIRS data for Aboriginal and Torres Strait Islander peoples, again by age in 2023 in the ACT and nationally, and a similar story across age cohorts compared to national figures, but also a similar story in that there was an interval reduction in the proportion of Aboriginal and Torres Strait Islander peoples receiving influenza vaccination between 2022 and 2023. They're on two different slides, but just to note that for the 50 to 65 and the 65 plus year age cohorts, the proportions are quite similar for the general population and Aboriginal and Torres Strait Islander peoples in the ACT, but quite considerably lower below that in the Aboriginal and Torres Strait Islander cohorts. Generally as well, just a good opportunity to reiterate, encourage the need to document Aboriginal and Torres Strait Islander status at both vaccine and non-vaccine clinical encounters whenever the opportunity arises. This is one final table before we move on to the next part of the presentation, and this is looking at influenza vaccination according to provider type from the beginning of March to the end of September from last year. So you can see that almost half of the 200,000 influenza vaccinations that were delivered in the ACT in 2023 were done so in a general practice setting, with 30 and 26% from pharmacy and other, where other includes health service sites like antenatal services, occupational flu clinics, residential aged care facilities, and corrective services as well. There's, relative to 2022, has been a kind of interval relative increase in the number and proportion of influenza vaccinations in pharmacy in particular. And we anticipate that this will occur even more so into the future with the introduction of the National Immunisation Program vaccinations in pharmacy, or NIPVIP program, from the beginning of this year, where eligible people will be able to receive NIP-funded influenza vaccines in pharmacy settings. And that generally includes people aged 5 and over meeting other eligibility criteria, which we'll go through soon as well in more detail. On to the influenza vaccine program for 2024. So these are recommendations and eligibility criteria which are unchanged for 2024. As with previous years, all people aged 6 months and above are recommended to receive an influenza vaccine, at least one influenza vaccine every year. In addition to that, some subgroups are covered by the National Immunisation Program for fully funded vaccines, and these include children aged 6 months to under 5 years, people aged 65 years and over, Aboriginal and Torres Strait Islander people aged 6 months and over, pregnant people.
Hello, everyone. It looks as though we've lost Ryan for a little bit. We'll just try and find him again and get him back online. Thanks. Okay, while we're trying to find Ryan, we might move to questions. And I think there is one question in the Q&A box, which I might leave because it's more of a ACT health question. But I would think, if it's okay with you, Philip, I just was wondering, two questions about the influenza vaccine you may be able to answer. One, are you aware of any progress on a universal influenza vaccine, so a long-acting one that doesn't need to be repeated each year? And also related to that, how many days into being vaccinated does the vaccine start to be protective? Traditionally, we've thought about it starts 2 weeks after you've had it, but is there any kind of evidence that it starts earlier?
Yeah, good questions. With respect to the universal influenza vaccine, that absolutely is the holy grail, and I'm not aware of any meaningful progress from a sort of clinical or public health point of view, but there's a lot of research in this space. And one of the big areas of development in vaccinology has been the mRNA vaccines. People will be aware of mRNA vaccines for COVID-19. That was the really key platform that accelerated everything. And there's a lot of work looking at mRNA vaccines for quite a number of the respiratory viruses that I mentioned today. So that's universal vaccination. With respect to time to protection, I don't think you'll ever get people away from that sort of 2-week window. But the truth is, if you've had prior exposure and then you expose to one of these antigens, depending on how tightly the current vaccine relates to prior vaccines, you will get a much earlier response. So by day 5, you'll get a very significant IgG rise, for example, to hemagglutinin. And that does correlate with protection in many people. So no, you're not going to get away from that sort of 2-week thing. But the truth is, for many people who've either had a vaccine before, or the very, very many of us, of course, beyond infancy, who've seen quite a few influenza seasons and been infected, you will be getting a protective response probably by the end of the first week.
So, Dr. Britton, do you have any recommendations for strategies for vaccine fatigue? I think as GPs, we've all kind of seen people roll their eyes and say, oh, another vaccine. Do you have any kind of recommendations how to cope with that?
Yeah, so the first thing I'd point people to, and I know it's hard for everybody to be pointed to resources first, but there's a particularly good resource called SKAI, or Sharing Knowledge About Immunisation, that's produced as part of a social science collaboration that's linked to the National Centre for Immunisation Research and Surveillance. And that resource is fantastic because it gives all sorts of conversation scripts for different people where you assess they might be relative to decision-making around immunisation or vaccination, and really focuses on the idea of relationship building and relationship maintenance. What we know for all of the vaccines, but particularly for flu vaccine, where it's been studied quite comprehensively, is the most important determinant of vaccine receipt is a confident recommendation from a trusted medical practitioner. Now, when I say medical practitioner, I'm not sure that there's good evidence to say that would be different if it was a pharmacist or not, or a doctor or not, or a nurse or not. I don't want to suggest that it's that clear. But a trusted clinician who says, I really think that you should get this vaccine is a critical determinant. So I would like to say to all the GPs out there in ACT, I think you should be really confident. The vaccine is not perfect, but it does work, and it works particularly well for children with medical comorbidity and for H1N1, and that we really should be recommending these in line with the national recommendations, even though it's seasonal, and even though we have this concern that, people don't think flu is a big problem. The truth is, if you recommend it to them, many, many more will take it than you think.
Thank you for that. That's very convincing. Okay, we'll now move back to Ryan. So over to you, Ryan. Thanks.
Thank you again, guys, and sorry about what's happened now, but just thought, obviously take a bit of an interlude for some questions halfway through spontaneously. Hopefully no other issues, but thank you for staying put. Just in terms of the Program 24 and NIP eligibility, as well as the people aged 6 months and over with certain underlying medical conditions, I did just want to stress as well that children under the age of 9 and anyone receiving their first influenza vaccination after hematopoietic stem cell transplant or CAR T-cell therapy should receive 2 doses of influenza vaccine 4 weeks apart. Next slide, please, if that's okay. Thank you. So this is also unchanged. This is a list of medical conditions that are firstly associated with an increased risk of influenza disease complications and also qualify people for funded NIP vaccination for influenza. So a long list there, which I won't go through in detail because, as I said, it's unchanged. But I did also just want to stress that there are other medical conditions and other groups of people who do not qualify under the NIP medical conditions qualifications here, but who also stand to benefit from influenza vaccination. And this includes groups like people living with obesity, chronic liver disease, and others. Next slide, please. This is just a quick slide to show a quick reference poster for NIP-funded influenza vaccines in 2024. This was distributed as part of the influenza provider packs and information that have been rolled out recently, and extra copies of these posters can be requested from the ACT Health Vaccine Management Unit if required or requested. I did just want to touch base quickly those last 2 vaccines shown here, the Flucelvax Quad and Fluad Quad. These are the only 2 NIP-funded influenza vaccines that will be received by pharmacies, as these cover the 65 and over age groups and the 5+ with qualifying medical conditions or risks. So I just wanted to note that there. Next slide, please. So this slide is just a look at a table that shows all the NIP and private influenza vaccines for 2024, the vaccines across the top and the age TAGI and the 2024 update guidelines. Recommend having a copy of this handy for a number of reasons. Compared with 2023, one change I just wanted to stress is that third from the left there, the Flucelvax quad is now recommended for 6 to 24-month-olds, as having previously only been 24 months and up. And it's also, as you can see there, all the white cells stand for NIP funded vaccines, and the asterisks show kind of conditional, so they're the at-risk groups or other qualifying conditions. So just wanted to know if you can see the Flucelvax quad has the 5 to 60 and the 60 to 60, 5 to 50 and 50 to 65 age groups with that asterisk, so conditionally. Whereas we have Vaxigrip Tetra and Fluarix Tetra on the left are the only two NIP-funded vaccines available for the 6 months to under 5 years cohort. On the far right, you can see Fluad Quad in white there. Down the bottom is the only NIP-funded influenza vaccine for 65 and up age cohort, and this is an adjuvanted vaccine. To the right of that is the Fluzone High Dose Quad. These two are both preferentially and equally preferentially recommended for the 65 years and up age group, but only Fluad Quad of the two is funded under the. More generally, I just want to suggest that this table is a really useful reminder that all influenza vaccines have some kind of age restrictions, whether it be for the NIP or just in general. And in order to avoid errors, encourage you to identify a suitable vaccine for your patients at the time. Next slide, please. Thank you. This is a quick slide on focus groups for 2024 and some general information as well. And Prof. Britton has already brilliantly covered most of this during and after his talk. Those focus or priority groups, children under 5, First Nations people and pregnant people were all noted, as was the sharing knowledge about immunisation resources and NCS resources as well. These are all really useful and practical evidence-based ways to approach discussions about vaccines available to Australians and the diseases they cause to address any concerns and questions people might have. But in general, promoting the free vaccine or free vaccines to eligible groups across the board is a big focus, certainly for 2024 and for every year. Next slide, please. Just a bit more information on those priority groups and looking at pregnancy. Again, these recommendations are unchanged, but just wanted to flag that influenza vaccine is recommended in every pregnancy at any stage in pregnancy and can be given safely at the same time as pertussis and COVID-19 vaccines. Co-administration of vaccines will be something we discuss a couple of times tonight. And just also wanted to flag that if someone who becomes pregnant has had an influenza vaccine either in the previous year or season, or even in the same year or season, but before becoming pregnant, they should be revaccinated or vaccinated during pregnancy. Next slide, please. Just a very brief chat about egg allergies. Obviously, this has been a topic of concern in the past, but the Australasian Society of Clinical Immunology and Allergy, ASCIA, has a statement on egg allergy and influenza vaccine, which essentially states that all available vaccines are considered safe and the risk of anaphylaxis or a severe allergic reaction is very, very low. The bottom half of the slide shows a table from the Australian Immunisation Handbook that again just demonstrates, regardless of the allergy and severity of the allergy, vaccination with a full age-appropriate dose is recommended, just for those with anaphylaxis to egg, perhaps in a medical facility with staff experienced in recognising and treating anaphylaxis as the main precaution. Next slide, please. Thank you. So just speaking a bit about the distribution plan for the ACT for NIP-funded influenza vaccines this year. Initial distribution is well and truly underway from the ACT Health Vaccine Management Unit, distributing over 50,000 doses of NIP-funded influenza vaccines to almost 250 providers across the territory over and beyond early April. Just on ongoing ordering information and order packs were and have been included with the resource packs that were sent out and distributed during the initial rollout. And again, wanted to flag, we also do have the NIP vaccinations in pharmacy or NIPVIP program from this year with vaccination with NIP, influenza and other vaccines for 5+ age group in a pharmacy setting. Next slide, please. Moving on to some other respiratory viruses and vaccines. Firstly, COVID-19, just some recommendations here. And again, Prof. Britton has touched on some of this, so I won't harp on, but influenza vaccine, again, with co-administration, maybe influenza vaccine may be co-administered with any COVID-19 vaccine in a 5+ age group, and XBB 1.5 containing vaccines are preferred, although again, generally and are limited at the moment to 5+ age group in terms of who is eligible to receive. There are updated ATAGI recommendations for both primary course and booster vaccination, again, which has already been touched on. But generally speaking, primary course for 18+ or as young as 6 months with risk conditions, which can be found on the Department of Health COVID-19 vaccination website. And then different considerations or additional considerations for those with immunocompromise may require additional doses. And then a table, again, which we may have seen earlier, looking at booster doses for different age groups with and without severe immunocompromise. And finally, just wanted to flag for this slide that much like influenza vaccines, both NIP and private COVID vaccinations should be uploaded to the Australian Immunisation Registrar. Next slide, please. So again, won't spend too much time on the RSV therapeutics as it's been covered very well to date, but just briefly wanted to highlight that for RSV vaccines, there are two. Arexvy is the brand name for one, which is now privately available and approved for those aged 60 and above. Recent recommendations by ATAGI are that Arexvy should be for people 75 years and over, or Aboriginal and or Torres Strait Islander people, or those with certain risk conditions from 60 years and up. Very, very briefly, Abrysvo is another, which is not yet available, and there is no ATAGI guidance at present. Nirsevimab has been covered, monoclonal antibody given intramuscularly, and passive immunity or immunoprophylaxis. Just wanted to note that the ACT will be participating in the recently announced New South Wales Health RSV Vulnerable Babies program. However, the extent of the involvement is yet to be finalised, and more information will be provided once it's available. Next slide, please. This is a more general look at winter wellness with some key messages from ACT Health. One which I think has been made abundantly clear, not only in children but across the board, is that respiratory viruses are more than just a cold and can cause very severe disease and death. Vaccination is an easy and safe way to protect the community from severe illness. And I've got the point there that so it should be or can be a focus on preparedness for before getting sick. So we do suggest that people who are high risk of severe illness are encouraged to speak to their primary care team about what to do and to have a plan if they become unwell. That may involve things like using the ACT Health antiviral pre-assessment form as shown on the right there, or to consider testing what may be available and appropriate, including RATs available for purchase and PCR with a pathology referral. More generally, also reminding people to take these recommendations and suggestions to maintain their own health and to do so for your patients as well, in order to maintain health and prevent passing on illness to others. These tips include practicing good hand and respiratory hygiene, staying home if unwell, and considering wearing a mask if you must go out, and taking steps to maintain physical and mental health during the winter months, like remaining active, eating well, getting adequate sleep, and spending time outdoors. Next slide, please. Thank you. Just a quick slide on shingles. Just noting that Shingrix has replaced, as of last year, Zostavax on the NIP, and is recommended as a 2-dose course for people aged 65 years and over First Nations people aged 50 years and over, or immunocompromised people aged 18 years and over with eligible conditions. And these are things like hematopoietic stem cell or solid organ transplant, hematological malignancies, and untreated or advanced HIV, noting that, unlike Zostavax, Shingrix is not a live vaccine. The main consideration here is significantly limited supply as well, and so there is a recommendation to prioritise first and second doses for immunocompromised individuals. Next slide, please. Thank you. Just wanted to note as well that adverse events following immunisation, or AFIs, are notifiable in the ACT. These notifications can take place by phone call to the ACT Health Immunisation Unit. Phone number is listed there and online, or perhaps more simply using the AFI reporting form, which can be found by searching online for AFI ACT Health or something similar. Email and fax contacts for the immunisation unit are also available on the slide there. Next slide, please. Thank you. So just some key take-home messages relating to the 2024 influenza vaccine program. Again, we've kind of touched on most of these points in more detail, but I'll just note that the influenza vaccines are recommended for people aged 6 months and above, and NIP funded for the groups listed there, with those priority groups that have been mentioned a couple of times in bold, so the children 6 months to less than 5 years, Aboriginal and Torres Strait Islander people aged 6 months and above, and pregnant people at any stage during their pregnancy. All influenza vaccines, both NIP and private, as well as some others as mentioned, must be recorded on the AIR. And just wanted to flag as well that there have been some other updates to AIR reporting, including the opportunity to add the type of vaccine in terms of whether it is NIP funded, private, state-based program, or antenatal. Influenza vaccines can be co-administered with COVID-19, RSV, pneumococcal vaccines, and others as well. And again, just wanted to flag that kind of each respiratory vaccine recommended or given also presents an opportunity to discuss and consider other vaccinations that people may be eligible for. And just circling back to that point about the 65 and up age group again, the adjuvanted Fluad quad and the high-dose Fluzone high-dose quadrivalent influenza vaccines are equally preferentially recommended over standard influenza vaccines, but only the Fluad quad is NIP funded. Next slide, please. This is just a slide with some useful resources, some of which we've already touched on, like the adverse event reporting form for AFIs, contact details for the immunisation unit, the AIH, ATAGI statements, NCIAs and SCI as well. And final slide, please. Thank you so much. This again has contact details for the ACT Health Immunisation Unit, and also a QR code for an evaluation questionnaire that was mentioned earlier. This should take less than 5 minutes, provides us very valuable insights into how to improve aside from spontaneous cutouts next time. And we'd be very grateful for your input in that regard. So that's it from me. Thank you.
Thank you, Ryan. I think you did a great job. Yeah, just to encourage people to scan that QR now, or we will also, CHN will also be sending out a link in the next couple of days. Could you return your evaluations within the week? That would be much appreciated. So now on to the question and answer session. And if we can go speedily through them, we've got 4 questions there, and we've probably got another 10 minutes of speaking. So what I might do is join 2 questions together for the ACT Health people about supply. So one's about supply of Fluad. One practice seems to have run out, and the other one is about supply of Shingrix. So if we're able to get a brief response from ACT Health about that, that would be great.
Hi, Leonie, it's Alison Kingsbury here. So certainly with the Fluad, we know that Fluad is the most anticipated vaccine of the year, certainly in Canberra. So the first couple of weeks are always really busy. If you've run out, please place an order with the immunisation unit, and we'll get that out as soon as we can. unscheduled orders can take up to 10 days at this time of year. I think that it's important to note that we base the initial flu rollout numbers on practice and pharmacies' usage last year. So we shouldn't have any problems with that, but it's just settling down. A lot of people like to get their vaccine in the first couple of weeks that it's available. So, yeah. Shingrix, yes, the $64,000 question. We have been increasing our rollout of Shingrix as we are able. So we have limited supply from the Commonwealth, and as does every other state and territory. So when we get some more stock, we will certainly send it out to you. We're not keeping it back for any particular reason. Just to note that it is an ongoing program, and we have been advocating really hard to get increased doses.
Thank you very
Sorry,
much.
I don't have a better answer for you, Leonie.
No, that's all right. That's great. Thanks very much. So now we've got a question. If we both have Flu-Cell-Vax Quad and other vaccines for people under 65, like VaxiGrip Tetra, both funded under the NIP, should we prioritise Flu-Cell-Vax to specific patients, and how do we choose who to give which one to?
I can try and answer that one. There's no preference with regards to Flu-Cell-Vax Quad or VaxiGrip or Fluarix in terms of who to prioritise for what. I guess it may be a bit of a balancing act, noting that 2 of them are for the under 5 age group as well. But it's not that there's superiority in one over the other. So no preferential requirements there for those 3.
Thanks. And then co-administration of Prevnar, influenza, COVID, and Shingrix. I think I read online that if possible to give Shingrix by itself. Maybe that's because it's got kind of stronger post-vaccination side effects, but is there any hard and fast rules about that?
There's not a lot of data. Ryan, jump in if you want to. There's not a lot of data on the co-administration of Shingrix with other vaccines. So while we're not saying it's the right thing to do, we're not saying it's the wrong thing to do either. But yeah, preference, just separate days.
Yeah, I'd agree with that. And just the co-administration same-day safety was more relating to the respiratory vaccines in that regard.
Noting that it is a clinical decision. So I guess if you are concerned that someone won't come back or they're a very vulnerable person, then it's really up to the clinician.
Yeah. I think last year there was something about Fluad and Shingrix, just being careful about co-administering them, but it's not an issue. And Fluad and Shingrix obviously would be ones that you would co-administer because they're the eligible age group.
Yeah.
So the last question for the night is, how long is the flu vaccine effective for, roughly speaking?
Ooh. Phil, do you want to answer that?
Yeah, good. Look, it is a very interesting question, and effectiveness for flu vaccines is hard to answer in total because it does depend on which particular virus, and they're quadrivalent vaccines because there's 4 influenza virus, antigens that you're vaccinating against. So it's a complex question. But if I was to try to summarize in total, there is evidence that once you get beyond about 4 months after vaccine receipt, that there can be some waning in effectiveness. Okay, so what do you do about that? Because one of the challenges is you're trying to give this vaccine to cover a season that we don't know whether it's happened yet, right? We don't know the timing of the season. That's the challenge with influenza vaccines, or always. So give it once it's available, give it early to people, particularly at high risk, because they want to be covered. But you need to understand that the longer you get from that dose, there will become a tipping point where the effectiveness begins to wane. And that tipping point probably is about 4 months, but it doesn't wane. It's not to wane precipitously, but it does particularly drop off against H3N2. There's a fair bit of evidence to support that, but I wouldn't want to delay vaccinating once it's available for a whole host of operational and personal and seasonal reasons. So it's great that people are keen to get vaccinated in the ACT, and it's great that people are ready to go.
Thanks. So we'll wind it up now. Philip and Ryan, and do you have any last quick messages you want to put out there, or you're happy?
Keep calm and keep vaccinating.
Yeah, thanks.
And immunised.
And immunised. Yeah, okay. Thank you. Okay, so we'll wind it up there now. It's nearly 7:30. Thank you very much to our speakers. You were really great and managed with the technical difficulties. And thank you all to the attendees for sticking with it. It was very educational. And we look forward to the annual influenza updates from the ACT Health. I know that they're really well subscribed. So thank you to ACT Health for putting it on as well. CHN will email you out a certificate of attendance, and please feel free to report 1.5 hours of educational activities to your CPD home. And we'll also be sending out the presentation slides and YouTube recordings as well. So thank you very much, everyone, and go get vaccinating.
Thanks, Leonie.
Thanks.
Thanks, guys.